Salam alaikum. My name is Dr. Yasir Salam. I'm a neurology consultant. I have been in practice for the past 20 years. I am board certified by the American Board of Neurology and Psychiatry and by the American Board of Internal Medicine. We're here today to discuss an important topic, a topic that I'm sure every one of you will be coming across numerous times throughout his career. We will be discussing altered sensorium, or a change of mental status, or a change of level of consciousness, or delirium, many terminology for the same entity. The goals, the objective goals for our lecture today will be to learn how to triage and categorize patients, and how to identify patients who are in need of prompt attention, how to generate a preliminary diagnosis, and based on your history and physical and your brief clinical examination. Also how to order tests and how to interpret the results of these tests, how to provide appropriate immediate management for those patients who need it, and then ultimately to learn when and where to refer the patient for the next level of care. Let's start with some simple definitions. What is sensorium? It's basically the ability of your brain to receive and interpret sensory input and stimuli from the environment. A good sensorium requires an alertness and awareness. Normal consciousness or sensorium requires, as we just said, arousal and cognition. Arousal is typically mediated by the reticular activating system, which is based in the brainstem, and cognition is a function of both cortical hemispheres bilaterally. A good working relationship between these structures will provide the patient with a good sensorium and a normal level of consciousness. Any disorders or derangement affecting either part of those could result in coma, lethargy, stupor, or this is in case the level of arousal is depressed, but also the level of arousal could be elevated and still yet abnormal, such as in confusion or agitation, amnesia, hallucination, and even seizures. So the cognition is basically a spectrum. When it changes, somebody could present just he's not the same as he used to be, all the way up to complete acute confusion, amnesia, and hallucination. To make things easier, we divide typically the level of consciousness into 6 different levels. The first 2 are typically normal. You are an alert person if you are awake and responsive and interacting with your environment. You could be drowsy, like if you have had a bad night of sleep or preparing for an exam and didn't sleep well, you're tired. You feel drowsy, you tend to doze off, and but you are promptly awoken or responsive when you are called by oral command. In a deeper level, we call a state of letharginess, where the patient is similar to sleepiness. However, they don't become fully alert. You wake them up, their verbal response is slow, and they are unable to perform a simple mental task, such as counting backward from 20 to 0. The next deeper level of disturbed consciousness is somnolence, where the patient can be aroused when called or touched. However, he cannot maintain his alertness, and you need to keep stimulating him to keep him awake. He may be able to follow some commands. The next level would be obtundation or stuporous. The patient aroused only when repeatedly or vigorously stimulated or called, but he does not produce any verbal output, or it's unintelligible. and he may be able to do some purposeful movements, such as pulling his hand or arm away from painful stimuli. And the deepest level of disturbed consciousness is a coma, where the patient does not awake even if you vigorously stimulate him or call him. There is no purposeful movements with the observation. He may have some posturing, and we'll be discussing this later on in the lecture. And brainstem reflexes are typically absent. So basically, it boils down to two things: the disturbed level of consciousness. Either the both hemispheres are not functioning well, or there is something affecting the reticular activating system. This is a common presentation. This is something you will see frequently, as I mentioned earlier. It could count up to 10% of emergency room visits, especially from elderly patients presenting by their family or loved ones with a change of mental status. Up to 50% of those patients needs admission to the hospital. You will also encounter those patients with this presentation, not in the emergency room alone, but also in the ward as a consultation. This is a very common reason for consultation for neurology or psychiatry or internal medicine at times. You could find this up to 30% of elderly patients who have been admitted to the medical ward with another medical problems, and then they turn out or they develop a change of level of consciousness subsequently. In ICU and elderly patient, the rate of incidence could go up to as high as 80%. Typically, there is an increased rate of mortality up to 10% with patients presenting with acute change of mental status, especially in the old population. So that's why it's important to promptly recognize a condition and to do a structured, brief, and focused examination, and to initiate management promptly. Most common causes of such presentation would be a systemic infection or metabolic derangement, but there is a whole host of other etiologies and very wide range of differential. Some of them are benign, and some of them can lead to irreversible brain damage. So again, keep in mind that a simple urinary tract infection in an elderly or fragile patient can present with the coma or with the encephalopathy. But from your examination and evaluation of the patient, there are signs or symptoms which could tell you that there is something neurologically happening, and these are the most common or the most important cerebral disease signs. If somebody presents with dementia or confusion, we know it's something neurologic, not metabolic. Somebody with a language problem or aphasia, seizures, visual field defect, and finally a patient with the mood or personality or behavioral abnormalities, especially if this is associated with the abnormal neurological signs. We need to remember one more thing, that this is not a diagnosis, it's a symptom or a presentation of another diagnosis. Our job as a physician, when we first evaluate this patient, to figure out the underlying etiology, to see why this patient is confused or encephalopathic or delirious. Again, the causes are quite extensive, and it could be as simple as reversible hypoglycemia. You give him dextrose intravenously and the patient would wake up. Or it could be permanent and more damaging, such as a stroke. It could be benign, like alcohol intoxication, or life-threatening, like encephalitis or meningitis. So basically, we need to establish a structured approach for such patients. If the patient is awake or not completely comatose, the provider must start with presenting himself, introducing yourself, speaking loudly, asking the patient what's his name, what's going on, what happened, how does he feel. If the patient responds to you, good, appropriate answers without any apparent distress, this suggests that his ABCs are intact and there is no sense of urgency. However, if he fails to respond to such simple questions, then this is an emergency presentation or an urgent case and need to be evaluated completely, starting with ABC management. So let's go through the simple and step-by-step process of evaluating such patients. We need to get clues. You are here like a detective. You need to try to figure out what's going on with this patient and what's a potential etiology for such a diagnosis. So try to get any information from the history. And remember, this patient is typically unable to provide history. He's confused or unresponsive. So anything from the emergency department, anything from the ambulance report, or by contacting his family or relatives through by a cell phone, anything from a bystander witness account. If the patient has been to your facility before, I would review his medical file. We need to review his medication list, check if the patient has any alert bracelet on his wrist telling us any medical information, or in his wallet. And we need to review his medications. Medications is the most common cause of change of mental status, and they could account up to 30% of these presentation. So this is the most important first step in evaluating such patient. If you have access to the medication list, you need to review them by one, see if there has been any changes of dosages, any new additions. Don't forget to review the over-the-counter medications, sleep agents, antihistamines, herbal supplements, and such. The next step is we need to try to establish a time course for this presentation. Had this happened over the past few hours or day or two? This represents an acute presentation, acute change of mental status, and this is a medical emergency. You need to make sure that the patient's airways are intact and patent, and his circulation and blood pressure and vitals are stable. You move on to check the vitals and the glucose and the oxygen saturation, and then we'll follow with a quick medical and focused neurological examination. If there is a history of trauma, or you suspect the patient has had a trauma prior to his presentation, then a trauma type exam should be initiated, allowing for a complete survey of the patient, regardless of the etiology, with the trauma in mind. Rapidly assessing the airways and breathing and circulatory status, and then you move on to evaluate the Gag Reflex and the GCS score, Glasgow score, coma score, and anything less than 8, that's indication for intubation. In examination, you start with the blood pressure, with the heart rate, vitals, temperature, respiratory rate, oxygen saturation. We need to obtain a finger stick blood glucose, and if the glucose level is low, promptly treat hypoglycemia. You initiate the cardiac monitoring and check if the patient has any unusual odors, such as alcohol, methanol, other drugs, or other odors. From this point, the blood pressure could direct you towards neurologic versus non-neurological etiologies. For example, if the blood pressure is less than 90, it's unlikely that this is a CNS or a brain lesion, and we need to look into metabolic and medical etiologies. While a systolic blood pressure above 170, you are most likely dealing with a brain lesion, such as intracerebral hemorrhage or a stroke. You move on then to the cardiopulmonary exam, a quick one. Check the lungs, check for any rouse or wheezes, check the chest for any scars of cabbage or a pacemaker, cardiac murmurs, any irregular rhythm, suggest atrial fibrillation, possibly with embolic stroke as a presentation. You move on to the abdomen, bowel sounds, any ascites, any organomegaly, hepatomegaly. You think of hepatic encephalopathy, any aortic aneurysm, any rebound or guarding or rigidity. On skin examination, look for jaundice, any needle tracks, indication of possible drug abuse, any petechia, check the skin temperature by touch, hydration status, dehydration. If you presented with somebody who has just lost consciousness or with syncope, and his skin feels moist and cold and somewhat pale, this could be an indication of a cardiac arrhythmia leading to the syncope. Then we move on to the neurological examination. Typically, we start with observing the patient, any automatism, any abnormal movement or jerking, hiccups, sneezing, yawning, myoclonus, tremor. Then inspect the patient for any signs of head trauma, any bleeding from the nose or ears, any CSF leakage. Sensory examination, if the patient is awake enough to respond to you. Reflexes, you check the deep tender reflexes if the patient is awake, and check for ankle clonus. If he is unresponsive, you move on to corneal and gag reflexes and oculocephalic. Babinski's signs are always helpful. Motor examination by observation, see if the patient is moving one side more than the other, if he's paralyzed from in the legs, if he pulls to pain or touch. Part of the neurological examination, you need to do the Glasgow Coma Scale and to evaluate the level of consciousness. Also, you need to check the eyes and the pupils of the patient. Respiratory pattern in a coma could give you clues into the underlying etiology. For example, Cheyne-Stokes breathing can indicate an upper bilateral cortical dysfunction. It could indicate bilateral thalamic problems. It goes with tentorial or supratentorial herniation, and sometimes with deep metabolic disturbances. Other breathing patterns are shown on the slide, and they indicate various levels of abnormality or dysfunction at the brainstem level. On motor examination, if the patient does not pull to pain or withdraws, he may give you a posture, decorticate posture or a decerebrate posture. And these two postures are important in identifying the possible etiology of neurological cause for these abnormal movements. For decorticate posture, you could see the patient having a adduction of his arms, flexion at the elbows, flexion at the wrists and the fingers. His legs are extended, and there's a plantar extension of the ankles. This is typically a lesion above the midbrain or diencephalon level, and it can indicate bilateral cortical dysfunction. On the other hand, decerebrate posturing shows a patient who having an adduction of his arms, but their elbows and fingers and wrists are extended with some pronation. Legs are hyper extended also. This is a lower level of pathology below the red nucleus in the midbrain. Everybody should be familiar with the Glasgow Coma Scale and how to measure it. This is typically developed for patients with head trauma for evaluation and for prognosis of the outcome at 90 days, but many physicians use it for non-trauma patient, as it gives a certain unified idea about the level of consciousness of this patient. We typically rely on three inputs to get the score of the GCS: the eyes opening, and a verbal response and a motor response as shown on the slide. As for the eye opening, the score ranges from 1 to 4, and for the verbal response, it varies from 1 to 5, 5 being the normal oriented person, and for motor response from 1 to 6. The highest score, the normal score, is 15. The lowest score is 3. Remember, there is no 0 or 1 or 2 in GCS. Another important value to remember in GCS is number 8. A score of 8 is critical and infers a significant mortality risk. So if GCS is 8, intubate. Remember this phrase. Mild head injury ranges between 3 and 15. Moderate head injury from 9 to 12. Less than 8, severe head injury and coma. If there's no history of trauma and you are comfortable that there's nothing wrong with the cervical spine and the patient is unresponsive, you need to do Dull's eye and caloric testing. Abnormality in these two tests indicates cerebral dysfunction with intact brainstem. Examining the pupils of your patient is very important and could give you valuable clues. A pinpoint pupils, for example, is typically indication of a pontine lesion or hemorrhage, but also could be from overdose with opiates. Small reactive pupils can be metabolic or a lesion in the diencephalon level. A large fixed dilated pupil unilaterally is typically a result of a third oculomotor cranial nerve palsy. A mid-position pupils typically result from midbrain lesion. This is the Dull's eye examination and the caloric testing. Now, after you have examined the patient quickly, but systematically, you need to put your findings together. Think about what's going on with this patient. Is this a global process or is this a focal process? How would you summarize the state of the patient based on your physical examination? And what could be the cause of the underlying problem? These the clues you gather from the history and physical and from the physical examination and review of medication will help you decide what additional testing you need to do. So basically, after you evaluate a comatose patient, if you have a localizing sign, it's either infratentorial or supratentorial, and the possible etiology is either a stroke or a hemorrhage or tumor or abscess. If there's no lateralizing sign or localizing sign, you check the neck. If there's any neck stiffness, we could be dealing with the subarachnoid hemorrhage or with meningitis. If the neck is supple, then you are dealing with a diffuse process, either functional, metabolic, or medical, leading to functional neuronal depression, such as hepatic dysfunction, uremia, drugs and electrolytes abnormality, or it could be structural damage, such as brain hypoxia, cardiac arrest, and encephalitis. Now you move on to the differential diagnosis, and unfortunately, this is a very wide differential diagnosis and very big list of etiologies, but your structured examination and focus history would hopefully eliminate many of those potential etiologies. This could range from structural CNS, primary CNS problems to metabolic or pharmacologic, infectious, fever, intoxications, withdrawal, hypoglycemia, and many others as listed on the slide. Some people use mnemonics to help remember the potential etiologies. This is a nice one, AE, IOU tips, and the other one would be SMASHED, SMASHED. So after evaluating the patient, now you need to consider what to order and when to order certain tests and evaluations. You need to balance two things. Most commonly, we use a shotgun approach and order a battery of tests to help move things quicker and faster and casting a wide net in order to differentiate or to figure out the underlying abnormality. But also what you've learned from your examination and from history and physical will add more specific testing. Typically, all patients will need to have rapid glucose testing during the vital signs checks. Then you order blood tests for serum electrolytes, a CBC, which will tell you if there's any infection or a severe anemia, electrolytes up or down levels of sodium, potassium, calcium, magnesium, phosphorus could help explain the change of mental status. Check blood gas, and if there's any suspicion of carbon monoxide poisoning, you order a carboxyhemoglobin level. You obviously need to obtain kidney functions, CRP, liver function test, albumin level, urinalysis and chest X-ray to rule out infectious etiologies. And ECG and cardiac enzymes is also a must. Now, other tests should include a brain CT scan without contrast for all patients who are unresponsive or have acute change of mental status. And if you have a strong clinical suspicion of infection or meningitis, a lumbar puncture should be done immediately after the CT is reviewed. If there is a strong clinical suspicion of a stroke, and the brain CT scan is negative, and your patient is stable, you might want to order a brain MRI scan with contrast and with diffusion. If there's evidence of any liver problem, ammonia serum level, thyroid function test, cortisol levels, vitamin B12 levels. If you have, by the review of medication, the patient is taking any medication such as anticonvulsants, digoxin, theophylline, lithium, you need to obtain a serum level of these medications and drug screen for certain patients you are suspecting overdose. Serum osmolality for toxic alcohols. The other test here shown on the slide, depending on what you have gathered from the history and physical and by reviewing the patient's medical file. So let's go back to approaching the patient one more time. The most urgent basis comes first, ABCs. You establish intravenous access, you give oxygen, you do cardiac monitoring, oxygen saturation. You have checked your finger stick glucose. If there's any indication of trauma or possible trauma, you need to protect the spine using a hard collar until you clear it radiologically. If there is no clues and you have found a patient who is unresponsive with no bystander witnesses and no medical information, coma cocktail should be given, which should include thiamine, oxygen, naloxone, and glucose. And remember always to give the thiamine intravenously before you give the glucose to avoid precipitating Wernicke encephalopathy. You need to prioritize your tests according to the hemodynamic status of the patient. If it's unstable, you obviously cannot send them for radiology or for echo. You have to stabilize the patient first. If the Glasgow Coma Scale is low, you need to intubate him. Do the high-yield test first, like ECG and finger sticks and oxygen saturation and vitals, and send off your lab test while you're evaluating the patient. Chest X-ray, portable chest X-ray can be done easily without delay, but a CT scan can be delayed until you make sure the patient is stable to go down to radiology. Treatment depends on potential etiologies, IV fluids for hydration, dehydration, and hypovolemia or hypotension, or hyperosmolar states, or hypernatremia. supportive care and sedation for patients who are agitated and you suspect they're having withdrawal state. Antibiotics, empirically, if you're suspecting meningitis or urosepsis or pneumonia. If the patient is hypothermic, you need to warm him. If he's hyperthermic, you need to cool him down. If you suspect an overdose with certain substances, antidotes should be considered. If severe hypertension is noted, antihypertensives such as labetalol or nitroprusside can be initiated in the emergency room, as this could be causing hypertensive encephalopathy. Hypertonic saline for profound hyponatremia or for patient with seizure or status epilepticus. Steroids intravenously, dexamethasone for patient with known brain metastatic lesion and brain edema and change of mental status. So once you're done with all these things, once you think you know what's going on, our advice is always to go back and rethink your diagnosis. Re-examine the patient one more time. The picture could be changing. And as you get more information from your lab results and diagnostic test, you need to retest your hypothesis. Do not become emotionally attached to your diagnosis, as the picture can be changing frequently. You need to remember one thing. The only atypical presentation is a typical presentation. And in conclusion, you need to keep in mind a wide differential diagnosis for any patient presenting with an acute change of mental status. You need to do a systemic approach and focus, but step-by-step clinical examination, looking for clues by history, by reviewing of medication, or in your physical examination and neurological examination, which will guide you toward the potential etiology. You need to re-evaluate the patient frequently, and you retest your hypothesis and potential diagnosis frequently. Remember, it's focal if it's affecting in the reticular activating system, and it's diffuse if it's affecting both hemispheres, which could be metabolic or infectious. Good luck. Thank you very much.